third part, which will be covering the following lesions. Now that we are not talking of ILDs as such, we are talking pattern approach, but I would just like to address this issue of when to use the term interstitial lung diseases and to use the term diffuse lung diseases. You're welcome to use either of the two terms, they are both acceptable. Just to say, interstitial lung disease is a term which is opposite of the alveolar lung disease. That affected the alveolus, filled up the alveolus. This involves the interstitial which surrounds those alveoli. But all interstitial lung diseases are not diffuse. Yeah? So interstitial lung diseases can be like cryptogenic organizing pneumonia, only one lobe. All interstitial diseases are not diffuse. Now we come to the term diffuse lung diseases. We have already seen diffuse lung diseases which are not interstitial. We saw bronchopneumonia which had the nodules bilaterally. We know pulmonary edema has. So there is no one term to describe ILDs, but basically you can use, so there are a lot of diffuse DLDs which are not ILDs and a lot of ILDs which are not DLDs. But the term is often used interchangeably, broadly, when to suspect interstitial lung diseases on a chest radiograph itself. So if you get any of these 2-3 patterns, what is a reticular pattern? Now reticular, unlike the clear-cut bands that you saw of atelectasis, yeah, they were like fibrotic bands going across, and even in the patient with pleural thickening we saw fibrotic lesions which went across. These are more net-like. These are more like a spider web, reticular pattern. You have some nodules thrown in. In this patient, you don't have an obvious volume loss as yet, but eventually you will. But you do have a loss of definition of the cardiac borders and the diaphragmatic borders. You can't make out the interface, although there's no consolidation sitting next to it. So you know you're likely to be dealing with an interstitial lung disease, and which in this case is diffuse also. And then depending on the dominant pattern, you have the differentials. We can't see all of these now, we'll just see some examples. After you have labeled it the pattern, so we labeled it as reticular, nodular, combined, or if you clearly see honeycombing, ground glass opacity, we already discussed with consolidation what is ground. All these indicate, and I told you there the ground glass opacity will come again in the interstitial also, and will come in the air space also. If we have lower zone dominant disease, first and foremost, is there a disease at all? You compare, see the CP angle is not normal. So you at least have blunting of the CP angles, that's where it starts. CP angle is gone. Right side next to the diaphragm, you do have some reticular like opacities, and it's very nice for us now because we report almost nothing on films, so we can mag and mag and mag, make it darker and lighter and see everything. So yes, I see the spider web. So appropriate age, smoker, I see lower zone dominant, reticular pattern, I would label it as a idiopathic pulmonary fibrosis, a UIP pattern. So that's how the pattern plus the location helps you. We are back to the post-infective like patient who had fibrotic strands this time with pleural thickening, upper and mid lobe dominance besides post-tubercular sequelae is seen with sarcoidosis. So this is the PMF. This is the PMF I promised you. You can see the hilar enlarged, they are also rounded and densely calcified. Believe me, differentiating sarcoidosis from silicosis can really be a challenge on a chest radiograph. And I just want to bring out one point here, that what has happened in current urban India today is that a lot of what is silicosis, what we clearly label as silicosis, has no occupational history of silicosis. So don't depend that to make a diagnosis on silicosis on an occupational exposure alone, because of this complex entity of anthracofibrosis, because of the complex exposures essentially linked to the construction industry. So if you see silicosis, you can label it as silicosis regardless of whether the patient has worked in a known silica background or not. But on a radiograph, it would be difficult for us to tell a chronic sarcoid from a silicosis. So we would go on to do a CT and we can tell the difference on CT. But these are the two differentials for a radiograph like this. Then, as I said, if you see associated adenopathy, we saw a similar case in the part 1, right paratracheal nodes, hilar nodes, and what I really like, I showed you at that time also what I called infrahilar, and after the infrahilar, the bronchopulmonary. You keep on following the node, the vessel keeps on looking nodular on the right side, right up to almost the level of the diaphragm. Now, this does not happen with tuberculosis, or seldom happens with tuberculosis. The bronchopulmonary node and the bilaterality really take you towards sarcoidosis. So, of course, you look for associated findings besides the lung picture. Now we come to assessment of lung volumes. So, you know, the strength of chest radiograph today, where does it stand today? Chest radiograph, most important, you already know, in emergency, most important in ICUs. But what about chronic respiratory disorders? Very important in chronic respiratory disorders. Why? Because you can't do a CT scan every day. Besides the cost and the logistics involved, in current digital scanners, a chest radiograph delivers a radiation dose of 0.01 millisieverts. Many times when I check on the system, it is even less than 0.01 millisieverts. Many times the system shows 0.007 millisieverts, 0.006 millisieverts. The chest CT, except the lung cancer screening LDCT, is finding it very difficult to break the 4 millisievert or 3 millisievert ceiling, which means that the conversion of one chest radiograph to 400 CT scans remains as relevant today as it was, you know, in the early days of CT scan, although CT scan has really managed to knock down radiation doses, but still the conversion factor remains of 400, because so has the chest radiograph knocked down. And just to, you know, bring in doses here, to say a PET CT today also stands at 18 to 20 millisieverts. So always remember those conversions besides the cost involved for the patient when you order an investigation. So the utility is you can put up 6 radiographs, and whenever I do film readings, you know, especially when patients come who are 20 years old, 30, I say bring chest radiographs from the day you were born, and it completely changes the diagnosis. So you cannot have so many sequential CTs. Another good thing is in ILD, looking at the lung volumes. You can quickly see the chest radiograph and see at what rate have the lung volumes been diminishing. Are there some lesions which cause increase in lung volumes? So those are the ones we are discussing, primarily the cystic lung diseases. We already discussed what a cyst was. We did not say what is a cystic lung disease. So there is no such term, definition of the term, but broadly, when the dominant abnormality is cysts, they are bilateral, they are diffused, it's a form of ILD which is labeled as cystic lung diseases. These are the ones which are usually associated with preserved and or increased lung volumes with, Langerhans cell histiocytosis and lymphangioliomatosis being the poster boys of this disease group. So this is a child of LCH. Now we come to, I told you lucency can increase or decrease. So this is called altered transradiancy, and it is all usually associated with some volume changes. So what is an opaque hemithorax? So the term is obvious. One side is opaque. After you label it as opaque hemithorax, the next step, where is the mediastinum? Contralateral mediastinal shift, ipsilateral mediastinal shift, or central mediastinum? So herein the mediastinum, if you go by 1/3, 2/3, you can't see the other half to calculate 1/3, 2/3, but yes, my right heart border is coming out more than it should. Yeah? It's bulging towards the right side, so there is some shift to the right side, definitely not to the same side. Then I will look at the spaces between the ribs. If I see the spaces between the ribs on the right side and compare them to the left side, so what is happening on the left side? definite increase. So there is something which is widening, as it is called, the intercostal spaces, pushing the mediastinum. So this is the push type of opaque hemithorax, which means either a massive effusion or a mass lesion. And then there is the pull type of opaque hemithorax. The pull type of opaque hemithorax is obviously because of collapse, or not a good word to use, destroyed lung, but there is hardly a substitute actually for that word. So whole lung is gone, and all the black that you are seeing on the left side is because of the herniated right side. And how do I know that? That is it the residual left side or is it the herniated right side? So see what happened to the hilum. The hilum has also traveled with the mediastinum and gone to the left side. So I know that is compensatory hyperinflation of the right lung because I see a reoriented right hilum. So this is the pull type. And then you can have one where the mediastinum remains in the center, but we like to say when the push and the pull balance out each other. Typically when there is a central bronchogenic carcinoma, so it's causing collapse also, but there is a central mass also, and sometimes in mesothelioma and all cases where as yet the volume loss may not be obvious, so you will get opaque hemithorax with a central mediastinum. Now we come to a unilateral hyperlucent lung. Again, whole story rests on increased lung volume, decreased lung volume, or normal lung volume. First you have to remember that it can be artifactual, like because of rotation. It can be a chest wall abnormality like Poland's or mastectomy, which you rule out upfront, that whether there is a history on examination. Once you have decided that the pathology is in the lung, so the increased lung volume group is obvious. There is a hyperinflation of the lung. You can see we discussed flattening of the diaphragm last time. So I said from the line joining the costo and cardiophrenic angle, we need 1.5 to 2 centimeters. You certainly don't have that. It's all flattened out. So flat diaphragm, herniated lung, you know you are dealing with overexpansion. And why is the lung black? Because more air and vasoconstriction, less blood vessel, both adding to the hyperlucent lung. But overinflation can happen with mild air trapping also, as in this patient we saw earlier, which is a case of asthma, oblique cystic fibrosis, ABP. I am not going into how to differentiate. And what happened if this lung, if this heart was not shifted? So I am not good, because unilateral hyperlucent lung is a very complex topic by itself, but basically small lung, yeah, we have to remember the overexpansion. What does small lung mean? Two differentials, basically hypoplasia and sphere James, yeah, that it's a small lung, it's a hyperlucent lung, it has less blood vessels but also has less alveoli, pulmonary hypoplasia. So we did overinflation. Now we are, I think, towards the end of our this thing on diaphragm. We discussed right is higher, occasionally both can be on the same side, occasionally left can be higher. What is the measurement wise cutoff? The measurement wise cutoff being right more than left by 3 centimeters is taken as abnormal. So if both sides go up, what does it mean? It means either a poor respiratory effort, there can be basal fibrosis like IPF in the lungs, but most commonly it means an intra-abdominal pathology which is pushing up the two diaphragms, like I already mentioned in this patient with ascites. So that's bilateral elevation. Unilateral elevation, I am showing you how you measure this unilateral elevation. We have measured to show you that this difference is coming at 5 centimeter, cutoff being 3 centimeter, associated pleural thickening. So unilateral elevation can mean, again, pathology can be in the lung, pathology can be in the pleura, or pathology can be in the infradiaphragmatic location like a subphrenic lesion. But this is the criteria for saying unilateral elevation. What did we discuss? When we are in the lower zones, we have to always remember the abdomen, and in the upper zones we have to remember the neck. So we do have this, I don't know whether this is raised dome of diaphragm, but earlier she showed a pleural mass which also had a convex upper border, which also had a mass lesion, which I couldn't see the diaphragm, and now this one also I can see the hard border through it, so posterior location is there. But can I tell that is it parenchymal or extraparenchymal? So if that air wasn't there, we think that it's most likely extraparenchymal. But the air is confusing, but it has a very well defined border. So is it above the diaphragm, is it below the diaphragm, or is it the diaphragm itself? So can't tell. So we have this air, but whenever you have air, remember it can either be air in the lung or it can be air in the stomach. Many chest tubes have been put in casualty on this mistake. The latest one I saw yesterday only, chest tube was not put, and interestingly, ultrasound is supposed to be very good for seeing the diaphragm, but in that patient we really struggle to see that whether we can see the diaphragm. But when you have eventration with all this colon having gone up, stomach having gone up, or you have a defect, it can get tough on ultrasound, and you would need a CT scan to show this. So this is in case of eventration, entire diaphragm has gone up with an gastric volvulus, because they are often associated volvulus. So whenever you see air like that, don't forget traumatic or all trauma related rupture or eventration with herniated stomach. So this is a patient with diaphragmatic rupture. So rupture versus eventration also becomes so difficult to tell on a chest radiograph itself. If you see a focal bulge, it can be focal eventration, it can be a focal tear, but many times the rupture is very large, and with this entire abdominal contents having herniated upwards. Suffice to remember, whenever you see air on the left side especially, which is supradiaphragmatic, always think of the stomach. This is the CT then detailing the entire length of the diaphragmatic rupture. Depression we have already done. One was that criteria, and the other criteria is the 10th rib. Hyperinflation, it's important in context of COPD and emphysema to kind of quantify and see whether there is depression or not. But more important is in case of tension pneumothorax, or when it is really causing the flattening in its extreme form becomes what is called inversion. So I didn't have a very good example of a gross inversion, but this diaphragm can go low down into the abdomen. That's when you know that it's bad news if it's a pneumothorax. So we will see what pneumothorax will look like. So we finished with parenchyma, and we are now on pleural lesions. Classical, this is classical pneumothorax, which means you can see an outer chest wall, you can see the inner visceral pleura. Everything is black between them. As I said, lung is also black, but this is more black, just like the cavity black, cyst black, because no pulmonary vessels. And important to identify the collapsed lung. The visceral pleura has to be seen, then you know you are dealing with pneumothorax. When it loculates, it sounds very easy to say pneumothorax versus when it loculates, especially when it gets multiple air fluid levels, becomes very difficult to judge that whether it's only a loculated pneumothorax or whether it is an abscess which has ruptured, and this is in the lung, there's an abscess. And so parenchymal versus pleural itself becomes a challenge, and believe me, the challenge remains on a CT scan also. It's not so easy on CT also to say, so everything can be take the CT. So what will you do? This always has a history. Like we said, cavities have history. A loculated pneumothorax, especially pyoneumothorax, has a history. Always look at serial radiographs, and what is our other friend in this situation? We will perform a lateral radiograph. So broadly we will be able to tell whether it's lung or pleura, but if it's both, it will show the long fluid level which we saw earlier of the pleural pathology. But yes, lung versus pleura, we can sort out this bulla versus loculated pneumothorax, because the bullae people only rupture and get. So bulla versus pneumothorax, lung abscess versus pneumothorax, it's very useful to do a lateral radiograph. This is a very old film of ours, but as I told you, it's the only one I had of inversion. So you see the bottom right corner of the film is where the diaphragm is sitting. So this is not flattening, this is not depression, this is inversion. So tension pneumothorax and huge pleural effusions do this, and for us it becomes a big challenge even after this to in big masses, whether it's inversion or whether it is defect, because what does defect mean? That half in thorax, half in abdomen. Inversion means all in thorax. Surgeon wants to know which approach should I take. Should I go from above and pull it down, up? Should I go from abdomen and pull it down? So for us it's a big challenge. We have to tell very clearly whether it's an inverted diaphragm or whether it's a lesion which is going through and through. After pneumothorax, the commonest is the pleural effusion, the classical free pleural effusion. Homogeneous opacity. So this is one, you'll see this is the first time I used the word homogeneous. Why? Because I came out of the lung. I came out of the lung, so I can call it homogeneous. Can something be homogeneous in lung? Yes, whenever it's filled with water, like a cyst. So homogeneous, right mediastinal border is gone, right diaphragmatic border is gone, and it has its highest point is lateral in a gentle slope. So this is a free pleural effusion. So if you want to drain it, you can put an ICD even without an added ultrasound and you are fine, because this is a free pleural effusion. On the other hand, why is this not free? Why? Because there is a part which goes right up to the apex. There is a part which its medial border towards the lung becomes convex. So I may want to do an ultrasound to see whether a single chest tube will suffice. Do I have multiple pockets? Is it already an empyema? So that is the significance of a loculated effusion, that the pattern of drainage, planned, and the etiologies become different. CT showing the thick peel of the visceral and parietal pleura instead of a thin white line around the gray fluid, it's a thick line. And then there is this confounder. As I say, it's a rounded lesion. I can see, so I would label it as a mass. It's more than 3 centimeters. I can see most of the margins, maybe just not a wee bit of the lateral margin. Then we do the lateral radiograph, and I would locate it in the lingula because it is anterior to the oblique fissure. But what is the differential in these lesions? So usually you see it on the right side. Left side does not have a minor fissure, but you can have accessory fissures, or you can simply have loculated fluid which hangs from the lateral chest wall and can simulate a parenchymal lesion. So as you see the lateral radiograph at the bottom, there is pleural effusion also. Suffice to remember that in setting of a pleural effusion, when you see a lesion like this, then it's important to differentiate whether it's truly a parenchymal lesion. We get lots of healed empyemas as pulmonary nodules for FNAC or biopsy, even if they have been treated for that empyema 8-10 years back. These nodules can persist, maybe not this big, but up to 2-3 centimeters they can persist, like areas of round atelectasis. So just remember that even loculated fluid can do it, usually does it on the vanishing tumor comes on the right side. The other concept is subpulmonic effusion. So case number 3 showing similar radiograph. One was a pleural lesion, one can be, what did we see? A gastric volvulus with eventration. And what is it in this case? This is a subpulmonic effusion. So subpulmonic effusion, diaphragm is elevated, its lateral peak, not so obvious in this, may appear to be a little outside, its peak is a little lateral, but you do the lateral radiograph, loss of density. So it simply means that it can either be lower lobe or it can be a posteriorly located parenchymal lesion or posteriorly located pleural, both things. But I have ultrasound today, it comes to my rescue, you do an ultrasound and you know it's a subpulmonic effusion. Pleural thickening, basically what you need to remember is pleural thickening is that if it becomes more than a centimeter, causes erosion of the overlying limbs, then you suspect a malignancy. Otherwise, we see it most often in context of tuberculosis, and in this case you see what's happening to the ribs. In the apex, they are completely, what gives you the drooping shoulder clinically, completely pulled down. The trachea is also shifted. So although it's measuring more than 10 mm by criteria, and no, I'm not dealing with a Pancoast tumor. More likely it's simply a pleural thickening. This is a zoom picture to show you the pleural thickening. Pleural calcification, very important to recognize because very often missed on frontal radiographs. You see what it looks like? It's not peripheral, it's covering up the whole lower zones. Yeah, because you have taken a frontal radiograph, it's covering up the whole lower zones, but still I'm telling you this entire lesion is not, nothing of this is in the lung parenchyma. All of it is in the pleura. So how do I know that all of this is in the pleura and none of it is in the lung parenchyma? Because if you look at the left side, I look at the bottom left corner, lateral border is very sharp. It's a single line parallel to the chest wall. No parenchymal lesion can do this. Parallel, it's called a sheet-like opacity or a plaque-like opacity. Similarly, shift your eye right side of the diaphragm, just above the diaphragm, see something which is parallel to the diaphragm. Thick white line parallel to the diaphragm. So this configuration is characteristic of pleural calcification, and although asbestos is common cause of pleural calcification, but it doesn't give rise to this calcification. This happens only when the empyema heals or the hemothorax heals, because the asbestos calcification is very fine. Okay, now we do a couple of illustrative cases and we close by just putting all our knowledge together. So 15-year-old boy, he has fever and he also has on and off cough. What is all that I see? Yeah, so I have a checklist. I can see some nodules in the lungs, but I have a checklist, so I have to see everything. I see miliary nodules, that's right, because they have no zonal predilection. They are distributed bilaterally. They are 1 to 3 mm. They are well defined. I have a right paratracheal stripe widening, so I'm dealing with a parenchymal node. It has a convex outer border. I have middle lobe consolidation, and I know it's middle lobe because it's limited superiorly by the horizontal fissure. I see the sharply defined fissure. I have history, and then I have the diagnosis. Do I need to do anything further? No, I don't. According to the new RNTCP guidelines also, thankfully, now they have a chest radiograph in the guidelines, but you don't, in an appropriate setting, whatever the current status of TST, I'm not going into, but you don't need to image further because the constellation of findings have given you the answer. Then I have a lesion which is collapse of the lung, it's gone to the left side, and then it's completely collapsed, and then it's aerated. Nobody did anything here. It's coming and going, it's coming and going, nobody did anything. But obviously in its worst form, it is opaque hemithorax with ipsilateral shift. This is suggestive of mucus plug impaction. We've seen it in a lot of people with hemopsis. So whenever a blood clot gets stuck, I had a child who was 12, 13 years old who used to throw this, every couple of months, that every time he had hemopsis, the lung used to move like this, and then it will expand on its own. So I just want to say that the strength of chest radiograph lies in the serial imaging, and the importance of serial imaging cannot be overemphasized. Never try to interpret a single radiograph if you have older radiographs available. This is, sometimes you have a spotter. I didn't do too many ICU cases today, but what is this? Vertical air lucencies adjoining the left border of the mediastinum, very sharp Spinnaker sail sign, say pneumomediastinum. As I said, consolidation heals and then you are left with lesions. Right middle lobe consolidation was given ATT or goes on getting because it's a non-resolving area. And then you do the lateral and it shows you this blobby thing along the posterior chest wall, which is not a parenchymal lesion at all. Why? Because it is simply a small pocket of loculated effusion. So as I said, watch out for these small pockets. nothing is to be done about them, because you don't need to prolong therapy, nothing reaches that pocket. But important to recognize that on a frontal radiograph alone it can get confusing because there's surrounding fibrosis, but combined with a lateral radiograph I know that this is a loculated fluid. You can verify it on one CT, but that's it, and you can stop. So fortunately lots of diseases but only a limited number of patterns, and you keep your approach going, you should be correct a lot of times at least. Thank you very much.